hypoglycemia is a common presentation, one which is often missed. And in the case of hypoglycemia, often we may not be able to reach a diagnosis, and that may have a lot of disastrous consequences for these hypoglycemic disorders, and we'll carry forward from that perspective. Uh, you can all go and have a look at our website, where has got a lot of information, including resource in pediatric endocrinology, e-learning platform, our courses which are there, including fellowship and pediatric endocrinology programs, our grand rounds, our journal clubs, and other activities which regularly happen. Our books, which are available both online as well as the hardbound version. Our mobile application, which guides. 8-month-old male child was presented to us with frequent episodes of irritability, lethargy since is 1 year and 4 months of age. But as contradiction to the previous case, this time the mother has noticed there are frequent hypoglycemic episodes associated with those problems. The child has multiple episodes during that episode, and especially it has been seen in cases of intercurrent illnesses and when the child is refusal to feed. So this case is different from the first case because it's a later onset, more episodic, and especially in the setting of this. So what do you think is the sort of a presentation? 1 year onset with frequent hypoglycemia. What type of disorders will be there?
Fatty acid oxidation.
Fatty acid oxidation defects, or else milder form of GST. Gluconeogenic defect can also present that. So what history will give you a clue that this is likely to be a gluconeogenic defect? During this episodes, what history will you ask for?
Gap between feeding.
Yes. Anything else? What is the feature of decay? Most common people will tell you is the
vomiting, abdominal.
And on examination, you will find that fast breathing. So if you are able to find fast breathing, that would be something which will also give you a clue that there will be acidosis also during these episodes. Carry on.
So moving on to the negative history, there was no episodes of like excessive playing before the onset or any onset of hypoglycemic episode after a protein-rich diet. There is no asymmetrical overgrowth of any body or face. The child doesn't have any failure to thrive or hypertrichosis or skin pigmentation. There is no history of any diabetic in his home, so there is no accidental intake of any or unintentional intake of any drugs, especially sulfonylurea. Their child had not undergone any gastrointestinal surgery. There is no history of any abdominal distension, difficulty in walking, especially waddling gait, recurrent infection or pediatric paralysis like picture.
Why are you asking for that?
I just wanted to rule out the GSDs.
Okay, you said GSD causes what type of fatigue?
Proximal.
So would they have periodic paralysis?
On present.
Very unlikely.
Yeah.
So to be more, see, every question you ask is like one investigation. So while you need to be extensive, it doesn't mean that you should keep on just trying to explore, because the attention span of the examiner will also be limited. So if you keep on talking about these things, they may get confused and they may start asking you in different directions. Okay, so carry on. So you have hypertrichosis is for?
Any sir insulin resistance like actually not.
Okay, so which form of hyperinsulinism are you thinking at this stage?
It is unlikely to be present.
No, that is obviously, but which form are you thinking of?
Insulin type B. Again, the antibody against the receptor.
That is usually happens in adolescence,
Yes.
not at this age group. So I'm not saying that it cannot be hyperinsulinism. Which form? That's why I'm asking. Things like GDH defect, milder forms of GCK defect may present sometimes like this. Very rarely you may have insulin producing sort of a scenario, which can also have insulinoma. It will be too focal form of hyperinsulinism. So, but the likelihood will become less likely.
HNF defects will also be present.
Yeah, and that happens usually in the neonatal period. The other important thing at this age group will be adrenal disorder. Many of the things like ALD, FGD, these sort of things can start producing at around 1 year of age. But then pigmentation will give you a clear-cut clue in that regard. Carry on.
There was no history of any weakness, lethargy, jaundice, or midline defect present in this child. So, birth history: the child was term child with 2.75 body weight with no history of any delayed cry during birth. There is no significant antenatal history, no breech presentation of forceps delivery. child was first born to the non-consanguineous marriage, and there is no history of any sibling death or miscarriage present. The developmental age of the child was according to his age. And if we go by the feeding history, the child was exclusively breastfed for the last 6 months, followed by complementary feeding. Right now, the child is taking the feed from the family pot. And the mother has noticed the child, the episodes happen, especially the time of fasting or intercalary illnesses when the child is not feeding well. So moving on to the examination, the child was a bit lethargic and irritable. He has a height of 91.2 centimeter, which is a less minus 1.32 standard deviation score, with a stress penalty of 5.2 centimeter. There was no dysmorphism or neurocutaneous marker present. This time the hepatomegaly was soft and it was not that enlarged, like 2 centimeter below the RCM present. There was other no midline defects present. Any CNS examination, chest and CVS examination is completely normal. So moving on to the investigations, and we found that on presentation, the blood sugar was 54 milligram per DL with a blood ketone level of 1.76.
So what does it mean? Is it significant,
So
insignificant?
this is a dicey situation where we don't know whether it is a ketotic versus hypoketotic. It is a less likely chance of hyperinsulinism because their ketone levels are much lesser than this. But we should keep open our eyes. So it could be hypoketotic versus a ketotic one.
So fatty acid oxidation
Defect
defect is a likely possibility here.
We did the urine for reducing sugar, though it is unlikely to present at this age. It is negative.
No, which condition can present at this stage?
Acha,
Fructosemia present late, sir.
Fructosemia nahi, fructose intolerance.
intolerance.
Fructosemia is different,
Fructose
fructose intolerance is different. So it can present. So that I've seen is typical case presenting at around 1.5 years of age, similar child, but lot of failure to thrive, large hepatomegaly, cataract, distal RTA, like picture. So that can present, but that is a different presentation altogether. And the classical history you get in fructose intolerance is that they will be eating the honey. No, that honey, how will they eat, mother? When they eat the apple, they will be eating only that part does not control the fructose. So they will be eating the periphery part and they'll be leaving out the core. So that is a very good history they'll get. So honey is this thing that honey may precipitate. But typically it happens after 1 year because that is the time when we start eating fruits and other things as well. Dal, everything has fructose. It's not that this only fruits will have fructose. Yeah.
Sir, the presentation would be a bit earlier for this child, or it will be like around when the
They are
feeding
not
started?
that sick, so the child presented a bit late. So depending upon how they come, it will be there.
Yes.
And the hypoglycemia will be one finding. It will not be the only finding. They will have so many other things. A lot of hepatomegaly, splenomegaly, and all those things are more common.
So insulin level was undetectable and cortisol was normal with a peak growth hormone level of 5.20 at 90 minutes of time. So moving on to our approach. So this time also the ketone levels doesn't give us a better clue whether it is a hypoketotic versus a ketotic one. But the one possible thing that it cannot be a case of fructose intolerance, as urine reducing sugar was negative. Hyperinsulinism is ruled out. It can't be a pituitary defect, unlikely, because growth hormone, though it is borderline, it will cause much more growth failure in the child, and single hormone deficiency will not cause that much hypoglycemia. Accelerated starvation is
It is a diagnosis of exclusion.
Yes.
So theoretically it can be,
Yes,
but
yes.
we have to rule out other things.
So now the possibilities. Possibilities are like glycogen storage disease, but seeing the hepatomegaly, which is soft, not that enlarged, other features like myopathies are not present.
And this is too late for GSD. The earlier one was too early for GSD1. This is too late for GSD1. They typically will present in 6 to 8 months. And if you do not diagnose by 15, 16 months, they will have massive hepatomegaly. Will not. So that is ruled out. But yes, 3, 6, 9, yes, they also have massive hepatomegaly.
And GSD1 gluconeogenic defect and fatty acid oxidation defects are the possible diagnosis, differential diagnosis right now present. So we moved on to the genetic diagnosis for this child, and which came out to be a fructose 1,6 bisphosphatase deficiency, autosomal recessive variant, and causing a gluconeogenic defect in this child as the etiology of the hypoglycemia. So this 2-year, 10-month-old boy presented with ketotic hypoglycemia and etiology being the fructose 1,6-bisphosphatase deficiency.
So if you compared those two cases, the first one had a much bigger liver, had hepatic dysfunction, high uric acid. Other things were not done here.
No, sir, not done. It was matlab the child was
Because we were anyway thinking of a possibility because fatty acid oxidation defect is a big thing. You don't want to miss it. Because if you do an induced fast in fatty acid oxidation, you can cause arrhythmia. So that's why we were thinking genetic diagnosis will be better. But if you look at that level of ketones and everything, it is fructose 1,6-bisphosphatase was an important presentation.
So the management it is usually the frequent feeding with nighttime snacks, and sometimes the protein-rich snacks is advised. There is a advice that not avoidance but the reduction of the fructose from the diet is preferred. And if acidosis is that much severe, we can sometimes go for some.
One message, I have seen a patient who presented to the emergency, typically diagnosed as decay. What happened was the sugars were not very low. Somebody found ketoacidosis and they gave some insulin, hypoglycemia, then gave dextrose, sugars went up. So the classical presentation could be a recurrent ketoacidotic episode in the setting of fructose 1,6-bisphosphatase deficiency. So acidosis can be a big issue in that perspective.
And there's the hypoglycemia will be there. The
Hypoglycemia is not, so that's what I'm saying. Hypoglycemia is not that severe as compared to GST. So, but yes, hypoglycemia is there, but it is missed. It may be missed. If they feed, they will not have hypoglycemia for 12 hours. That's the problem. When you talk about glucose homeostasis, we are basically looking at in terms of how the glucose comes in our diet. It is absorbed via the intestine, and then it is used predominantly via the brain, the muscle. These are the major usage organs as far as that. And then if you have extra amount of glucose, it is stored in the liver. So liver is like your bank where you store all your glucose in the form of glycogen. Now this glucose can also be stored in the kidneys as glycogen, and it is then excreted there, which is prevented via the SGLT2, which we know all that. So if there is a problem either at the level of feeding, problem at the level of glycogen storage or glycogen release, problems of glucose may be happening. Once you are fed and your glucose becomes more, it can be utilized via the brain, and then you will have this glycogen is providing you as a store in that perspective. So if you have problems in the glycogen synthesis or glycogen release, you will be if you have a problem in glycogen synthesis, of course you can't have enough glucose in the liver. So you will have, it's like somebody who doesn't have a bank account. When they eat, their sugars will become very high. And then when they starve, they will have no backup, they will become broke. So you will have fasting hypoglycemia and post-meal hyperglycemia. That is your typical presentation of two conditions, GSD0, which is glycogen synthase deficiency, or GLUT defect, in which the glucose is not being transferred. If there is a problem in the glycogen release, what's happening? You have deposited your money in the bank, and suddenly your ATM card is not working. So you have got a lot of money, but you cannot utilize it. You start using your alternate resources from that perspective. Now, kidneys can also produce glucose through gluconeogenic pathway, which is through fructose and other pathways. And when you have lost everything, the final reserve is, so if you have taken off all your bank account, you have sold all the ornaments, what is left? Property. You will sell the property. So fat is like your property, which the body uses as an alternate source. It burns the fat to produce ketones. So these are the defense mechanism. The first is whatever money you are making every day, that is surviving, that is like what you're eating. Second is you use your ATM to get food from the glycogen. Third is you're using all your money which you had stored in the form of some ornaments like gluconeogenic defect. And finally, you are selling your property to survive, which is your gluconeogenic, in which you're using your protein and fat to produce glucose. So that's the last thing the body wants from that regard. Now, we are mainly focusing about glycogen, so I'm not going to talk about other pathways. But remember, glucose is to be sent into the liver using GLUT2 and glycogen synthase and brancher. So glycogen synthase will add glucose to the glycogen, and they will be branched using the brancher enzyme. Now, this glycogen can then be really converted into glucose using debrancher, phosphorylase, and glucose 6-phosphatase. The most important enzyme of the carbohydrate metabolic pathway is the glucose 6 phosphatase, which is the common point for both the glycogenolytic pathway, the gluconeogenic pathway, the galactosemia pathway. All of them converge at the level of glucose 6 phosphatase to release glucose in that regard. Now, of course, pancreas produces insulin, which will try to store the glucose as glycogen. So it will increase the glycogen synthase and brancher activity, and it will inhibit the debrancher activity, which will release, so it will cause storage of glycogen. That is why hyperinsulinism, you will have hepatomegaly because of glycogen storage. Glucagon has got a lot of effects, but the major effect of glucagon is glycogenolysis. So it is going to release your glucose from that perspective and produce more glucose. Now, glycogenolysis is a process in which glycogen is broken down into glucose. The three major organs where glycogen is stored is the liver, the kidneys, as well as the muscles where it will be stored. It is converted via phosphorylase and phosphokinase to limit dextrin. What do you mean by limit dextrin? It is the point at which the branch comes. Once the branch comes, they cannot convert glucose. From the limit dextrin, you need debrancher enzyme, which produces glucose 6 phosphate, which is converted via glucose 6 phosphatase into glucose. So if you have a problem in the glucose 6 phosphatase, nothing will be produced. If you have a problem in the debrancher, you will have some production, but then after a time, you will not be able to produce glucose. If you have a problem in phosphorylase, phosphokinase, it will be even more. So the gap between feed and hypoglycemia will be the maximum for phosphorylase, phosphokinase, followed by debrancher, followed by glucose 6 phosphatase. So those conditions present more as a storage disorder, as hepatomegaly, liver dysfunction, and problems of myopathy, pain, exercise-induced problems, and all those things will be more likely. Now, as I said, glucose 6 phosphate is a common site. It is also being produced via the fructose 1,6 bisphosphatase. All the gluconeogenic pathway will also converge out there. It's like a confluence. So this is basically coming from lactate to pyruvate, which is then getting converted into glucose 6 phosphate. So now what I was talking about, if you have a problem in glucose 6 phosphatase, you will have a back effect. If you have a problem in fructose 1,6 bisphosphatase, you will have a back effect towards lactate. So only two conditions lactate will go up. In debrancher problem or phosphorylase phosphokinase, which is GSD 3, 6, and 9. This is what we talk about as milder forms of GSD. You will not have high lactate because lactate is not in their path. So this becomes important to understand. Now, galactose is converted to galactose 1 phosphate and then again via the same. So it's like a three confluence, Triveni sort of a scenario. All three are getting mixed up here. And the most important point, there is glucose 6 phosphatase. So if you have no glucose 6 phosphatase, there is no way your body is going to get glucose. You need to feed every 2 hourly. That is the big message from that perspective. So this provides backup in infants for 4 hours. So when I say 4 hours, that infant may not have fed for 4 hours. And that's why hypoglycemia happens. And then somebody is not feeding enough, you may present early. That's less likely, but it can. In childhood, it will be 6 to 12 hours, and then the issues would be there. Now, the second backup, which we are talking to discuss about, the second condition which you presented is gluconeogenic defect, which means production of glucose from alternate sources. So this is the last ditch effort. Everything is gone. You are selling your home to get the glucose. So your building blocks of the body are amino acids. You're breaking amino acids. So lactate and alanine are converted to pyruvate, which is converted via carboxylase to oxaloacetate, then pep carboxykinase to pep, and then fructose 1,6 bisphosphatase to, again, you get fructose 1 phosphate, and from there you get the glucose 6 phosphatase, which is working from that perspective. The fructose 1,6 bisphosphatase is also important because it is also the point where your fructose and glycerol come into the picture. So here you are linking your fatty acid oxidation, you're also linking your fructose to produce glucose. That is why Alapan was talking about that you should not give too much fructose. If you give them too much fructose, what is going to happen? You will have accumulation of other things, but not production of glucose. This is something important in this particular effect. And then finally, you have got glucose 6 phosphate, which is converted into glucose. Now, fructose 1,6-bisphosphatase is the most severe form of gluconeogenic defects. There are other forms also like PEP carboxykinase or carboxylase, which are milder. They will not have that many features and they will have milder lactate elevation. But yes, they can have, but they typically will present with other features. Gluconeogenesis provides backup for 12 to 24 hours in that perspective. Now, which hormone regulates which becomes important to understand. Insulin is a hypoglycemic hormone. So it will decrease glycogenolysis, decrease gluconeogenesis, lipolysis, and ketogenesis, everything. Your glucose will come down. In fact, it will promote your glycogenesis, it will promote your ketogenesis, it will promote your fat formation, and other things will be there. Epinephrine has got a major effect on glycogenolysis and ketogenesis with milder effects on other perspectives. Glucagon mainly works in the setting of glycogenolysis as well as gluconeogenesis, and growth hormone will clearly have a major effect on lipolysis. That is why individuals who have growth hormone deficiency look chubby or fatty in that perspective. And cortisol has a major effect on gluconeogenesis. But so there are four hormones which are regulating the counter-regulatory process. There is overlap. You can't just say that it's only that, but predominantly you can say that glycogenolysis is a glucagon phenomena, lipolysis is the growth hormone phenomena, gluconeogenesis is the cortisol phenomena from that perspective. So anybody who is fasting should have a glucose which is less than 50 milligram per DL. Insulin should become undetectable. Cortisol level should be above 550. Growth hormone should be more than 10. But sometimes these counter-regulatory, if they are long-term deficient, may not be that low. So then you can have some exhaustion which may happen from that perspective. Now, other scenario would be your glucagon should be high. So giving extra glucagon should not increase your level of glucose with the exception of hyperinsulinism. So that is something to remember. Glycogen problem happens at 6 to 10 hours. Gluconeogenic pathway problems happen at 10 to 24 hours. And then subsequently, other parameters will be ketotic pathway will be 12 to 24 hours, which will give you a picture. If you give glucagon, there will be no increase in glucose. If you in fact have a glucose 6-phosphatase defect, the lactate will increase in a fed state. So glucagon test is a way to differentiate gluconeogenic defect from fructose 1,6-bisphosphatase deficiency in that regards. So all processes are important. At 6 hours, you can see 90% is glycogenolysis. As you go from 12 to 24 hours, 24 hours, the glycogenolysis becomes less. The other pathways become important. So timing and gap between meal becomes a very, very important process to understand from that perspective. So we go one by one. So glucose 6-phosphatase defect, the problem is at the confluence of all the three pathways. So you will have no glucose production. Glycogen is going to be stored in the liver. Fructose is not working. Galactose is not working. So glucose is not going to increase from that regard. More glycogen will basically mean it will be accumulated in the liver and in the kidney, causing hepatomegaly and renomegaly. You will have high level of cortisol, epinephrine, growth hormone. All the counter-regulatory hormone will be more. Ketosis will be there because you will produce ketone. Triglyceride will go up because of all these counter-regulatory hormones. Uric acid will go up because of the action through that pathway which becomes activated. So you will have hypertriglyceridemia and high uric acid which is there. Glucose level will not increase after giving glucagon. You will in fact have a paradoxical rise in lactate which will happen with glucagon injection. The GSD basically is two types. GSD1, which is basically a defect in glucose 6-phosphatase with defective glycogenolysis, defective gluconeogenesis, presenting onset is 4 to 6 months with hepatorenomegaly, high lactate, ketone, and glucagon. GST1, 1B is actually a problem in the glucose 6-phosphatase transporter. So the enzyme is not defective, the transporter is defective. And in this scenario, the problem is similar to GSD1 with the exception of leukocyte dysfunction. So this case which Alapan discussed has a GSD1B which is there. The manifestation again is later, but you may have an earlier presentation. There is a greater predisposition to autoimmune disorders and infections in that regards. Now in debrancher activity, GSD3, you will have some production of glucose. But after the branch comes in, you will not be able to produce. You will have accumulation of limit dextrin. It has a delayed onset with hepatic dysfunction. This is a major presentation which will happen. And there will be myopathy because muscles also need a lot of glycogen to provide us with the energy levels in that regards. So GSD 6 and 9, they have a problem in phosphorylase kinase, which is a terminal defect. Manifestation is late with growth failure and myopathy. I have seen patients with these forms of GSD referred mistakenly as growth hormone deficiency because they'll be short, they'll be plump, they will be chubby, and that's why they are labeled as GSD. But in fact, they will have huge liver, and you can identify that in that regards. What is GSD 0, Dr. Sandeep?
The GSD 0 is due to glycogen synthase defect.
Okay, yeah. What happens there?
In this, there will be no production of glycogen in the liver, and there will be a deficiency of glycogen, so there will be no hepatomegaly.
So, is this really a GSD?
This is basically not a GSD, it's a misnomer.
So, in a classical sense, it's not a GSD, but it's a problem in glycogen metabolism. So, classically, as you said, the problem is in glycogen synthase. Synthesis does not happen. You will have fasting hypoglycemia. You don't have any bank account. So, when you need, you will not get the money. But whenever you get your salary, everything is overflow. So, you have post meal hyperglycemia. So, this is a paradoxical response which happens in the setting of a hypoglycemia followed by hyperglycemia. And this is a close differential of ketotic hypoglycemia. In fact, the recommendations are if you're labeling somebody as ketotic hypoglycemia, you in that scenario give them glucose and see if they become hyperglycemic. That is important to remember. Now, GLUT2 or Fanconi-Bickel syndrome is again an important scenario in which you will have a problem in the renal and hepatic transport. You will again behave like GSD 0. So again, 6-month onset fasting hypoglycemia, post-meal hyperglycemia. We have seen patients who are presented more with renal abnormalities in the form of Fanconi syndrome like that, but they can also have hypoglycemia, which is their RTA and glycosuria. Finally, the gluconeogenic defect, the problem is at the fructose 1,6 bisphosphatase or of course PEP carboxykinase and carboxylase. Here, you will have no production of glucose which is happening through the alternate pathway, so it will be later onset, typically after 1 year. So this case presented 16 months. This is the typical presentation which is happening. Your lactate will be high in fructose 1,6 bisphosphate deficiency, and you will have ketone which will be present. There will also be no increase in lactate after glucagon. So why do you think this happens? How is it different from GSD1 then? Why in gluten?
Why lactate is not high?
Yeah.
Because in gluconeogenic defect, if there is no accumulation of the lactate in the previous part. So
you have accumulation of lactate,
but it is a little amount than.
So compared to GSD1, you will have much more amount there in GSD1. Here it will be much lower. But of course, lactate is high in the basal state, but fed state giving glucagon does not increase. The fructose 1,6 bisphosphatase deficiency, the defect is onset after 12 months with high lactate and acidosis. It's a life-threatening condition. So if you now summarize the condition, enzyme defects, of course, GSD1 is glucose 6 phosphatase with massive hepatomegaly. You will have high levels of lactate onset at 6 months and they will develop hepatic adenoma. GSD3 is a problem of debrancher. GSD6 or 9 is phosphorylase or phosphorylase kinase, large liver. But their lactate will be normal. Onset is typically 12 months and you will have myopathy and transaminitis as a major presentation. GSD0 will have no hepatomegaly and they will have hypoglycemia, which is basically having prandial hyperglycemia. Gluconeogenic defect is fructose 1,6 bisphosphatase, where you have massive hepatomegaly with high lactate after 1 year. That is the diagnostic feature. So identifying this glycogen storage disorder is very important because it's not just about glucose. They have so many other metabolic defects. They have got dyslipidemia, they have got liver dysfunction, renal dysfunction, RTA, muscle problems. So this can be a big problem, and all you can do, if you give them periodic glucose, you will improve. Now that is,
As we all know, GSD is a genetic metabolic disorder of liver with defective glycogenolysis and gluconeogenesis both in GSD type 1. Defective glycogenolysis but intact gluconeogenesis in GSD type 3, 6 and 9. and defective storage of glycogen or glycogen formation in GSD 0. There is also defective enzyme which converts galactose or fructose to glucose, and they are converted to unwanted glycogen stores like lactic acid, fatty acids, uric acid, which is harmful, and therefore there is risk of hypoglycemia during the periods of fasting. There are two types of carbohydrates: complex carbohydrates, which takes longer time to digest, like bread, cereals, grains, rice, pasta. Simple carbohydrates, which digest easily, like glucose, galactose, lactose, fructose. Therefore, our diet should include more of complex carbohydrate, and it should be less than 5 grams of simple sugar. Total fat intake should be
So
20%.
why do you want to restrict the amount of simple sugars?
So because of in postprandial hyperglycemia immediately after.
So what will it cause? You may have hyperinsulinism.
Insulinism.
You don't want that to happen. So if your body is having low sugar, so insulin is adjusted in that regard. If your sugars goes even slightly up, you will have immediate hyperinsulinism. Something like when you treat hypophosphatemic rickets, if you give too much phosphorus at one time, what happens?
If we give too much phosphorus in hypophosphatic rickets, the phosphate will inhibit
The phosphorus goes up,
phosphorus goes up. So
PTH comes in,
PTH will be increased.
it will wash it out.
Okay, it will
So here, if you give too much simple sugar, you'll have hyperinsulinism, which is going to wash off your hypoglycemia. So that's why this is important. In this point, you want something like a slowly releasing. So if you can get a depot preparation of glucoside sort of a thing, that will be a better phenomena in that regard. So you say just go back. This is the most important point. So you're saying bread, cereal, grain, rice, and pasta. But usually they will not have enough to sustain. So problem happens at night. It's not that the daytime they will can feed 4 hourly. That's not a big problem. But night is the major problem. So, but these things, do you think they will take care till 12 hours? So often patients with diabetes say in the night, my sugar, when I say it was 120, morning also it was 130. So despite taking insulin, so how did that sugar go up?
Because of hepatic release of.
So hepatic glucose production is a major thing. How much does the liver produce every milligram per kg per minute, do you think?
4 to 6.
4 to 6. So this is such amount. So 4 to 6 milligram per kg per minute. If you translate that, now this is how you can work out is how much grams you will need per day. That is the amount of, and particularly in that 12 hours, because that's very, very crucial. So that your bread, cereal, grain, pasta may not be able to do that. So of course, delaying your feed will become important. Incorporating them may be important. How else you can increase their duration of action? So for the same carb, how can you prolong the duration of action is by decreasing the glycemic index. How do you decrease the glycemic index? If you take only a bread or if you take a fried bread, fried bread will be longer acting. If you have cheese on that, it will be longer acting. So adding protein and fat may prolong that. So that is something also which is there. So taking a milk sort of a scenario may be better. Giving a glucose will be very hazardous because that will have very high, low, very high, very low. That is something which is avoided. So carry on.
Fat requirement is 20% of total daily calories with equal distribution between monosaturated, polyunsaturated and saturated fats. Cholesterol intake should be less than 300 milligrams.
So again, this is a sort of a double-edged sword. Your triglyceride is very high, so you don't want to give too much triglyceride. But still, if you don't give fat, your glycemic index may become very high. So this is something which is there. So we will counter that with the next part, protein.
The goal in GSD is to maintain normoglycemic state in between meals. So we can have cornstarch. In infants, there is a limited amount of pancreatic amylase production, which helps in digestion of uncooked cornstarch. Therefore, in infants, it is preferred in daytime to have frequent feeds, and in night, nasogastric tube feeding is preferred using enteral formula or glucose polymers. In more than 1 year, we can use raw cornstarch with a dose in children less than 2 years being 1.6 gram per kg every 4 hourly, and more than 2 years with 1.75 to 2.5 grams per kg every 6 hourly.
How do you get this cornstarch?
So there is a available pack.
So it's easily available. It's basically like it's used for various preparation. So it's not available as cornstarch. It's available as corn Corn flour. It is available as corn flour in the market. If you go to the supermarket or the grocery store, they'll give you corn flour, which is available. So this is very, very important. NG feeding is the treatment of choice. It is like your continuous pump sort of a scenario, but that is not easy to identify. So this becomes like your land test. So you can say cornstarch is like a long-acting insulin, while that is like an infusion of insulin. So that is a better way. But then having a NG feed continuously monitored and you don't have any aspiration, all those issues have to be considered.
Therefore, the allowed sugars are glucose, dextrose, dextrin, maltose, corn syrup, aspartame, acesulfame K. Sugars that are not allowed or are limited in to be consumed in limited amount is fructose, galactose, brown sugar, sucrose, maple syrup, or raw processed sugar.
So we already discussed that fructose really comes through the different pathway. And the other thing about fructose is, what does fructose do to insulin?
Increases.
It's a more potent stimulus of insulin than glucose. So fructose is something you won't want to give too much. That can cause more problems in terms of insulin release.
Fructose and galactose should be less than 2.5 gram per meal.
Yes.
Fruits contain fructose, should be consumed in moderate amount. Milk and milk products contain lactose, should be used in limited amount. We can use unsweetened soy milk, and since the consumption of milk and milk product is limited, we have to supplement child with calcium and vitamin D. Sugary drinks should be avoided. Sugar-free tea, sugar-free drinks can be taken. Artificial sweetener have sorbitol, they should be avoided as they get converted to fructose. In GSD1, the main role is of raw cornstarch. It acts by hydrolysis and digestive tract and releases glucose molecule. It is slowly digested than other complex carbohydrate, provides 30 to 45% of daily calories, prepared by dissolving in lukewarm water and shaking the container well. It should be mixed with fluid just prior taking it. Should not be mixed with spoon, as the cornstarch will stick to the spoon and child will not receive the correct dose. It should not be heated or cooked because it will break down. And meal should be consumed prior to taking cornstarch because it will make child feel full. Because the duration of action of cornstarch is 4 hours and it requires at least one feeding in the middle of the night, the extended release cornstarch was developed. Using structural modification was done. Waxy maize starch known as glyphosate with duration of action of 7 to 10 hours. It advantages was that middle of night feeding was omitted and there was improved sleep and quality of life. Disadvantages being a strong taste of corn and increased abdominal pain, flatulence, and diarrhea. In GSD 3, 3A is inability of liver and muscle to break down glycogen to glucose, and 3B is inability of liver to break down glycogen to glucose. The lack of glycogen access in muscle leads to muscle damage. Therefore, a high protein diet with low carbohydrate diet like modified Atkins diet is preferred in GSD 3, with protein requirement being 3 to 4 grams per kg per day. Advantages, it has been seen in various studies that it improves cardiomyopathy and avoid tissue deposition of abnormal glycogen. In GSD 2 and 4, there is no specific diet available. GSD 5, simple carbohydrates can be used. GSD 6, frequent carbohydrate meals or cornstarch to be used. And GSD 7, low carbohydrate ketogenic diet can be used. The monitoring of blood glucose and ketone is essential to determine the optimal balance of protein and cornstarch in patients.
You can all go and have a look at an app which also has a hypoglycemia interpreter which will help you reach the diagnosis, our courses as well as our platform.